So the next thing that I'm going to talk about is emergency head and neck radiology. And essentially what I want to focus on is head and neck radiology in the emergency room. And so some things that you may see at night in an acute setting. So the first thing that I'm going to talk about are infections involving the periorbital region. So this is a child right here that comes in with a very, very red eye. And so part of the challenge is that if someone comes in the middle of the night and they have an infection surrounding the orbit, you know, what are some things that we have to look for? So when we look at infections involving the eye, we always have to remember that there's a very, very thin piece of bone right here. And anybody remember the name of that bone? It starts with an L. Remember? See? Everyone is very interactive here. She was telling me last night, she scared me. She says, oh, people in Egypt are so shy.
She said that?
Yeah, she said that. They said people don't want to shout out answers because they're afraid they're getting it wrong.
I wasn't challenging you.
Yeah, no, this is great. Everyone's so happy. Pretty soon I'm going to ask everyone to come sit next to me. So I'm going to like me on Facebook. I'm on Facebook, so friend me. I need friends. So when we do talk about these infections that involve the periorbital region like this, the first thing that we have to consider is the concept of preseptal cellulitis. And who's heard of preseptal cellulitis? So the challenge with preseptal cellulitis is that we hear this term preseptal, but how do we know where the orbital septum is? Because if you don't know where the orbital septum is, we really can't separate preseptal from postseptal. Well, the way we do this is that there's a little sac right here that's referred to as the lacrimal sac. And the anterior aspect of the lacrimal sac is referred to as the anterior lacrimal crest. And the area posterior to this is the posterior lacrimal crest. And I think you can see this, but if you see this little sliver of tissue, can you see this line right here? Everybody see that line right there? That's the orbital septum, and the orbital septum attaches to the posterior lacrimal crest. So when we look at the normal anatomy, there are two main ligaments that we have to consider. There's the medial canthal ligament that has an anterior and a posterior component, and then we have the orbital septum that attaches to the posterior lacrimal crest. So in this particular case here on your right-hand side, this is the lacrimal sac here. This is the anterior lacrimal crest. This is the posterior lacrimal crest. So in order for this to be preseptal cellulitis, all of the infection has to be anterior to the posterior lacrimal crest. Does that make sense to everyone? The reason why it's important is that preseptal cellulitis typically does not arise from the paranasal sinus. Preseptal cellulitis is an infectious or inflammatory process that arises from some type of infection involving the skin. And whether or not this skin is due to a bug bite, an infection, whether it's due to impetigo, it can be due to various things. But preseptal cellulitis is just typically treated with oral antibiotics. Now, what's postseptal cellulitis? Postseptal cellulitis is that here's our lacrimal sac right here. Everyone see the lacrimal sac right here? And in this particular case, we can see all of this infection is extending posteriorly. Now, this is what we refer to as postseptal cellulitis. So postseptal cellulitis is typically due to infection involving the ethmoid sinuses. And if the patient has a postseptal cellulitis and there's any reduction in ocular motion, then these patients are either treated with very, very broad spectrum antibiotics or they're admitted to the hospital for intravenous antibiotics. So from our standpoint, part of our job is to determine whether or not radiologically there's a presence of postseptal cellulitis, because this is a more aggressive disease than preseptal cellulitis. And the only way we can make that differentiation is to understand the anatomy. See how anatomy is so important. The next thing that we'll talk about is the subperiosteal abscess. So this is an example of a subperiosteal abscess. So when we look at the spectrum of disease, we have preseptal cellulitis, postseptal cellulitis, now subperiosteal abscess. So subperiosteal abscess is felt to be due to an infection involving the adjacent ethmoid sinus, and there's small little draining emissary veins that communicate between the ethmoid sinus and the periosteal bone of the medial aspect of the orbit. So if we have an infection, essentially a thrombophlebitis of the emissary veins, this allows the transmission of the infected ethmoid sinus germs to the medial aspect of the orbit, resulting in the typical subperiosteal abscess. And this is debatable, depending on the clinical symptoms. Now in 2019, this can be treated with broad-spectrum antibiotics if the abscess is small, but if it's larger, this requires surgical drainage. Now, one thing to remember about subperiosteal abscesses, see this right here? You can have a subperiosteal abscess and have a completely intact bone. So you don't necessarily have to have bone erosion if the patient has a subperiosteal abscess. Why? Again, we have these veins that traverse the very, very thin lamina propria, and you can have a septic thrombophlebitis and have all these organisms extend medially to the medial aspect of the orbit. So realize subperiosteal abscess, the bone can be completely intact, so we have to be aware of that possibility. The next stage is the presence of this, and this is a frank intraorbital abscess. So it almost looks like we have three globes, 1, number 2, and number 3. And in this case, that third globe is just a very, very large abscess that's causing inferior displacement of the globe as is seen here. So this is a contrast-enhanced T1 weighted image with fat suppression. All of this bright signal, all of this enhancement is due to phlegmon involving the abscess. And if you look closely intracranially, what else are you seeing here? This is what here? Enhancement. This is all meningitis. So this is, the patient not only has an intraorbital abscess, but they have a meningitis. So another example of an intraorbital abscess, this case was an older case, but I'll never forget this. I don't know about how it's in Egypt, but all bad things happen on Friday afternoon. So Friday afternoon is the day before our holiday, so I guess it's Thursday afternoon for you, right? But I remember sitting down and looking at this case, and I saw, my gosh, this doesn't look right here, right? There's air back in the orbit, and when we look at the coronal images, this patient had a blowout fracture involving the inferior portion of the orbit, and this was never fixed, and so all of this infected sinus ended up extending superiorly, involving the orbit, and this turned out to be an intraorbital abscess. Now, this is a disease entity that I'll spend a little time on, because there's a saying in the United States that says you only see what you look for and you only diagnose what you know. Okay, and this was an interesting disease that is the last or worst complication of an intraorbital abscess. Now, does anybody know what the diagnosis is here? Wow, you guys are so good. It's cavernous sinus thrombosis. And so it's wonderful. So on a contrast-enhanced CT scan, what we see here is absence of flow within the cavernous sinus on the left and on the right. And this area of high attenuation right here is low signal on MR. And this low signal is due to what? It's due to clot in the cavernous sinus. So this is classic cavernous sinus thrombosis. So the thing about cavernous sinus thrombosis is I'm so happy people pick this up like that. It's wonderful to see. You're smarter than I am. When I was a fellow when I was a resident years ago, before I did my fellowship, I wanted to go into academics, and I kept calling my mentor up, and he said, I want to write a paper. And this was before the days of emails and texts, because my gosh, if I had emails and texts 30 years ago, I would have driven this person crazy, saying, just give me something to do, right? This is what phones and emails, etc. So finally, in order for him to get me to stop calling him, he said, I'm going to give you 6 cases of cavernous sinus thrombosis, and I want you to look at them. And the reason why I remember this paper is because in all 6 cases, the patients either had a severe neurological deficit or they died. Okay? But it's a devastating disease, but the sad part is that the initial diagnosis of the cavernous sinus thrombosis was missed. So it was present on the films, but it was missed. So that's why I say in cavernous sinus thrombosis, you only see what you look for and you only diagnose what you know. So after having done this paper years ago, I always remembered to look for it. And so for the residents in the audience and the people in universities, you're probably being encouraged to write a paper or do something scholarly. And the reason why I bring this up specifically is that every paper that I've written, whether how small it is, whether it's a case report or a small case series, you become an expert in that field. And even though you may not think it's important, your expertise is unmatched, and you will always take this information that you focus on, and it will stay with you for the rest of your life. And one day, I will assure you, inshallah, I will assure you, that you will see that case later in your life, and you will be aware of that. And so you will think of that diagnosis, and when you think of that diagnosis, you'll know it. Okay, so that's one of the reasons why it's always important to get involved in some scholarly activity. And this is one of those examples. So again, Friday afternoon, I was looking at this case, and lots of cases to read, and it was sinus disease. And I said, all right, well, there's some disease here in the sinus. And in the United States, we have something called voice recognition. So you dictate into the dictaphone. It's like Siri. It's a natural language processing. You see your dictation, and then you sign it, and it's gone. Now, back when I trained it, I don't know what it's like in Egypt, but we used to dictate into a dictaphone, and you have someone transcribe for you, so you have time to think. But now in the United States, things are so fast. So I remember dictating this case out, saying, disease involving the ethmoid sinus, next case. And I don't know about you, but have you ever felt impending doom? Right? I remember I dictated this case out. I was about to sign it, and I said, "Well, something's not right. You know, something's not right." Have you ever felt that fear? You can't explain it. And something's not right. Right? So I went back and I looked at this, and I looked at the fat in the orbit, and I thought, "Oh my gosh, this is not right." You see all this? See all this reticulation of the fat in the orbit? The orbital fat should be dark, but it was bright. And then I looked at it and I said, well, this doesn't look right either. There's something that's dilated here. See this? So I don't know about you in Egypt again, but in the emergency room, we don't get a lot of history. You know, we may get a one-word history, maybe two. I'm sure you get much more better history in Egypt, right? I'm sure much better. No. So I called up the emergency room and I said, is there anything else? And they said, oh yeah. I said, what do you mean, oh yeah? They said the patient has a 6th nerve palsy. So now we have ethmoid disease, reticulation of the retrobulbar fat. We have dilatation of this vascular structure. And what vascular structure is that? Superior ophthalmic vein. And we ended up doing a study to look for cavernous sinus thrombosis. So you can either do MR or you can do CT. In general, I like to do CTV, CT venography. It's quicker, it's cheaper. So notice here in the dural sinus, we can see good enhancement here. Everyone see that here? So we see enhancement in the dural sinus, but where do we not see enhancement here? So what's enhancing here? This is the artery. When we look back in the dural sinus, we can see venous enhancement. But if we see venous enhancement here, there should be venous enhancement in the cavernous sinus. Do we see any venous enhancement in the cavernous sinus? So that, in this case, we were able to make an early diagnosis of cavernous sinus thrombosis. And in this case, I got lucky. You know, there's an old saying in the United States that says, good judgment comes from experience, and experience comes from bad judgment. You ever heard that? I have experience, okay? I've made bad judgments before. I've missed things. This one I got lucky on. But I think the reason I got lucky on is because 25 years ago, I'd written that paper on cavernous sinus thrombosis. All right? All right, very good. Oh, I'm going to skip that one. We'll come back to that one. I don't know what that's doing there. We'll come back to that. Oh, wait a minute. Hold on for once. Where am I? Sorry about that. Did you load the right talk? Okay, good. There we go. Okay, all right. All right, everyone good with that? All right. So the next thing that we'll talk about now is a mass involving the neck. So everyone's favorite in the middle of the night is as a kid that comes in with a neck mass. Everyone loves that, right? It's terrible, right? So the first thing that we have to be aware about is that when we start looking at the pediatric neck and we start looking at lymph nodes, let's go ahead and make our definition of the difference between left and right. So both of these kids come in here and they have a unilateral painful neck mass. So we have a mass here, and then we have a different patient that has a mass here. So what's the difference in appearance between the mass on the left and the mass on the right? Both have contrast, but what's the difference when you look internally between the left and the right? Yeah, and what else about the mass? What else about the lymph nodes here? Are they homogeneous or are they not? They have some type of low attenuation within it. Whether or not it's necrosis, we don't know. It could be necrotic fluid, it could be pus, right? So that's the important observation. So on the left-hand side, when we see a matted group of lymph nodes, this is what's referred to as cervical adenitis. On the right-hand side, we have pus in the lymph nodes, and we talked about this earlier. This is what we refer to as suppurative adenitis. So the lymph nodes have become pussed out and they contain pus. So this is suppurative adenitis. It's not an abscess. It's pus in the lymph nodes. And on the right-hand side, this is still treated with antibiotics. So everyone understand the difference between cervical adenitis and suppurative adenitis? Okay. So this is an example. This child comes in, and you may see this in Egypt. I don't know. This child, what's that? What's that? Not Ludwig's, no. But remember Ludwig, think about that. That's going to come up later. This patient has a localized group of lymph nodes involving the left-hand side, and in this case, a different patient has this group of lymph nodes that's more suppurative in what space? Submandibular. You're experts in the spaces now, right? So, what do you think the diagnosis is going to be there? You have to ask me a question. It's a kid. Any questions you want to ask him about the history?
Cat scratch.
Ah, does he have pets?
Yes.
Or does she? Yes, has pets. So this is cat scratch disease. So cat scratch disease we typically don't see in the head and neck. Cat scratch disease is typically seen with little epitrochlear lymph nodes. Why? Because the cats have some type of saliva and they contain this germ that's referred to as Bartonella henselae. So if a child has a cut finger and the cat or dog licks them, then this bacteria is transmitted in the saliva and it typically goes to the lymph nodes adjacent to the epitrochlear in the elbow. But if for some reason there's an open cut, then these kids can present with enlarged lymph nodes that tend to be localized. So this is the typical example of cat scratch disease. Perfect, excellent. Now this is something you see more in Egypt than we do in the United States. So this is a child that has an infectious process that's involving the anterior portion of the neck. Anybody want to take a guess at what this is? What's that? No, infectious. Tuberculosis. Everything's tuberculosis. If I go to India, everything's tuberculosis, right? Yeah, and this is tuberculosis. So in the United States, this is actually scrofula, I guess. So this is tuberculosis of the anterior portion of the neck. Now, I showed this case for a particular reason. This was a case I read years ago. And again, you only see what you look for. You only diagnose what you know. I thought that this was metastatic squamous cell carcinoma involving a level 2 lymph node. And it turns out they biopsied this, and this turned out to be tuberculosis. So in the back of my mind now, every time I see a necrotic lymph node, especially in the United States where we have more squamous cell carcinoma than we have tuberculosis, I always have to think in the back of my mind. Here in Egypt, in the Middle East, and in South America, and in India, you already know this. But just realize tuberculosis is sometimes called the great mimicker. It can look like anything and it can occur anywhere. Okay. Another example here, I showed this earlier, this was Pott's disease. And this is just an example of what we used to call cold abscesses. These are abscesses, we used to call them abscesses. Actually, I think what these are now is that this is suppuration involving those retropharyngeal lymph nodes. Okay. Now this is everyone's favorite, right? A plain film of the neck, right, in a child. in the middle of the night. And all of your partners are away at a meeting. So it's just you, right? So now what we see here in this plain film, we have all this increased soft tissue involving the prevertebral area. So now you're really stuck. Now I showed this case before. I want to see how good your memory is. What's the diagnosis here? How many people say retropharyngeal abscess? Okay. How many people say suppurative lymphadenitis? Okay. And the answer is suppurative lymphadenitis, right? So the reason why this is suppurative lymphadenitis is that, yes, there's fluid here. Yes, it's well contained, but notice how it's localized and it's paramidline. So this is in a lateral retropharyngeal lymph node. And if you see this and the patients have a stable airway, the ENT surgeons know that this can be treated with IV antibiotics. This, on the other hand, is edema involving what space? Retropharyngeal space. And here's our anatomic diagram on the right-hand side. Now, I want to see how much you remember. There's a line right here. Anybody remember the name of that fascia that's there? It starts with an A. What's that? Alar fascia, exactly right. So if you see this edema involving the retropharyngeal space and you see this line, all that is just the alar fascia. So this is just edema involving the retropharyngeal space. Now this is the natural progression of a retropharyngeal space infection. So this is what? This is suppurative adenitis. Everyone see that? So it's not an abscess, but this is pus involving both lymph nodes. If this continues to get bigger and bigger and bigger, all of this pus can extend into the retropharyngeal space as it is here. Now, here's a retropharyngeal space, and what's directly posterior to the retropharyngeal space? Spine, right? So this is infection involving the retropharyngeal space. This is pre-non-contrast T1. Something's not right here, right? And then when we give contrast, we can see now we have a retropharyngeal space abscess associated with discitis and osteomyelitis that's resulting in an epidural abscess involving the spine. So this is the natural progression of disease if it's untreated. Suppurative adenitis, retropharyngeal space abscess, if it's untreated, it goes on to result in discitis, osteomyelitis, and it can extend into the spine. Everyone got that? Okay. Another example of a classic retropharyngeal space abscess, the key thing here, very, very large fluid collection in the retropharyngeal space, and notice how there's large expansion of the retropharyngeal space. That's a true abscess. And remember, one other example here, this was a child that had a toothbrush in their mouth and got pushed by the sister, and the toothbrush ended up penetrating the posterior wall of the pharynx, and unfortunately we have a fluid air level here, so watch out for your siblings, right? One other example of a retropharyngeal space abscess here, and this is being drained, and now we see all this pus that's extending out of the retropharyngeal space abscess. The other point that I want to make about retropharyngeal space abscesses is that the retropharyngeal space has a potential space, and the retropharyngeal space is in purple here. So this extends all the way down into the mediastinum between T2 and T6. Now, if you were listening earlier, I'm going to ask you, what was the name of the space that was just behind the retropharyngeal space that's depicted here in orange? Danger space, exactly right. The danger space extends all the way down through the mediastinum, extends through the crura, and then is continuous with the retroperitoneum. So the point is that anytime that you have abscesses involving the head and neck area, we always have to look down into the mediastinum, because the danger space and the retropharyngeal space both provide a pathway of spread for infections that can involve the posterior aspect of the pharynx to extend into the mediastinum. So in this particular case, the same patient ended up having a mediastinal abscess that is seen here. Okay. Now, this is a case I showed earlier. This was a case of calcific tendinitis. So is this normal or is it abnormal? How many say normal? How many say abnormal? Okay, there's 100 people in here and only 3 people raise their hand. Okay. What's Arabic for scared? Yeah, you're all scared. You're all chickens. Okay, all right. All right, so let's take a look. Let's take a look at this here. So, what am I pointing at right here? Do we see anything back here? Aha! What is that? Edema. Edema. So now you have someone that presents with edema involving the retropharyngeal space. So let's look at some more images. Normal or abnormal? What is that? Seven said it. Calcification. And then when we look at here, do you see it now? Dens and... So what is that? This is calcium hydroxyapatite. So this is what's referred to as calcific tendinitis. Now, calcific tendinitis typically involves the prevertebral muscles. And there is this pericalcific inflammation that arises from and results in edema involving the retropharyngeal space. And, excuse me, in fact, the way that I think about it, this is almost like gout of your neck, right? You know, you can get gout in your foot, right? And it's deposition of calcium hydroxyapatite. This is very similar to what we see in the neck, and this is calcium hydroxyapatite deposition resulting in edema. So if someone presents in the middle of the night and you see edema involving the retropharyngeal space, they're afebrile, look very, very closely for this calcification, because this is easily treated. This is just treated with an anti-inflammatory, basically aspirin. Does anyone see the calcific tendinitis here? Someone explain to me the abnormality. Is this normal or abnormal? Why? Edema. Perfect. Normal or abnormal? Okay. Okay. Whoops. There we go. Normal or abnormal? Is it abnormal at A, B, or C? A. Yeah, right there. See those calcification? So that's calcification involving the longus colli muscle. Again, it's there. When I first put this talk together, I'd never seen this before. Then I went back and looked at my reports and I missed it. So there's my experience coming through again. Another example here. There's edema involving the retropharyngeal space. Do you see it now? Right there. Got it? Okay. Once you've seen one, you've seen them all. Okay. You just have to remember to look for it. Got to remember to look for it. All right, good. Okay, both of these patients have infections. Okay. Now, this one has an infection here, and this one has an infection here. So the question I ask you is, what space are they in, and why does it make a difference? Both came in the middle of the night. So on the left-hand side, let me start with the right-hand side. It's probably easier that way. What space is this infection in? Peripharyngeal space. What space is this infection in? Visceral. Perfect. Why does that make a difference? Who cares? There's only 4 millimeters, right, between the tonsil and the peripharyngeal space. So why does that make a difference?
The airway, we have more peripharyngeal space. The airway is very dangerous, not like the tonsillar abscess.
So it's the other thing. So you're close. You're close. So the reason it makes a difference, it's a good thought, is that this abscess in the peripharyngeal space needs to be drained from a cervical approach. But this abscess involving the tonsil is drained intraorally. So it's all about the pathway they take in order to drain that tonsil. Good? All right. I'll try. I keep messing up. Sorry about that. My bad. Shukra. Cool. All right. So it's all about the pathway which it's drained, because if something's located in the peripharyngeal space, it needs to be drained cervically, but if it's located within the tonsil, it needs to be drained intraorally. So it's perfect. Perfect. So this is just an example of a patient that has a tonsillar abscess here. This is pre-treatment, right? And then after treatment, we can see that the abscess has been drained, and there's air here located in that residual capsule of the abscess. We talked about this earlier before. What space is this in? Oh, don't look at that. Ignore that, right? Okay. Sublingual space. We know that we always have to look for the sublingual space abscess. Anybody see it here? A, B, or C? A, exactly right. And anytime you see this, obviously, and you know this already, is to look for the bone, or look for the bone algorithms. And when you see the bone algorithm, we can see the small little area of erosion that's eroding the lingual cortex of the mandible. And this is typically due to an infected tooth, odontogenic infection, right? Now, who said Ludwig's angina? There's my man, there's my friend. A couple people remember Ludwig's angina. So this is actually Frederick von Ludwig right here, right? This was him right here. So it's always fun to go look up people's names because you have to figure what these eponyms are all about. So what Ludwig's angina is that Ludwig's angina is essentially a compartment syndrome that arises in the floor of the mouth and the sublingual space. So Ludwig described Ludwig's angina long before CT and MR. So he described this basically in the early 1900s. And the reason why the term angina came is that angina is Latin for strangulation. So these patients would end up having as you can see here, a severe infection involving the floor of the mouth that ended up pushing the posterior aspect of the tongue base posteriorly and now ended up compromising the airway. And because this infection also extended back, as you can see here, to involve the epiglottis here, this gave that strangulation feeling. So, believe it or not, the cardiologist stole angina from us, the head and neck radiologists. So, tell your husband, the cardiologist, tell him he's a crook. All right. So, angina actually means strangulation, and it was described originally by Ludwig at that time. But now it's felt to arise, to result in chest pain. So this is a classical example of Ludwig's angina. Another example of Ludwig's angina here, we can see multiple abscesses extending along the fascial planes of the sublingual space. And this is an example of an enlarged left aryepiglottic fold. Here's a normal aryepiglottic fold on the right side, and this is why the patients present with strangulation, that feeling of strangulation because of the compromised airways. Oh, and just for grins, what's located back here? This is what in the retropharyngeal space? Edema. Perfect. It's edema. You guys are so good. And why is Ludwig's angina important? Because when you do have these abscesses, they need to be surgically drained and incised. Now, here's another disease that can present in the middle of the night. Now, in order to make this diagnosis, there's some history that you have to ask me. So, has the patient ever been treated with chemotherapy or radiation therapy? The answer is no, and I'll explain why that. Has the patient been involved in motor vehicular accident? No, they haven't. Has the patient been coughing a lot? No, they haven't. Has the patient had recent surgery? No, they haven't. So what's the history? The patient's presenting with a severe, severe infection. So what's this disease entity called? What's that? Giant? Could be. Well, usually it's an adult. Why? What are you thinking about in a child? What'd you say? That's what it is. Yeah, exactly right. So, yeah. Everyone's interactive here. What are you talking about? They're not going to let me talk, you know? So this is necrotizing fasciitis. So how do we make the diagnosis? The reason is because of the air. In this case, it's involving the tongue. It's extending along the fascial planes. And another example here. Everyone see the air extending along this plane? So the way that necrotizing fasciitis, the way that we make the diagnosis as a radiologist is that we see a patient that comes in with a very, very severe infection. And when we look at the CT scan, there's air. But we have to be cognizant of the fact that you can have air after other treatments. So in this particular case, this patient had chemotherapy and radiation therapy, and there's air that's just outside the left thyroid cartilage. So if you have chondronecrosis actually develops nitrogen, and that nitrogen can extend into the fascial plane. So if you will, this can be typically seen after radiation therapy. But if you have a patient that's never been treated with radiation therapy, it has not been involved in a motor vehicle accident, has not been involved in, not had recent surgery, or had not have a big coughing. Because you know, if you can cough, sometimes you can rupture a small little bronchial branch and you can have air extending the mediastinum. If you see that, then you have to think of necrotizing fasciitis, okay? Again, I can guarantee you will see this one day, 100%. Typically it's in the abdomen, right? The accessory organ of the abdomen, but just realize it can arise in the neck. Now this is an example of a patient that comes in the middle of the night, and now you do CTAs here, right? CT angiographies, right? Yeah. So this patient had multiple head and neck cancers that had been treated with multiple recurrences. Now, if you have a head and neck cancer and they're treated with multiple chemotherapy and radiation therapy, sometimes they can present with coughing of blood. And if someone presents with a head and neck cancer that's been treated with radiation therapy, chemotherapy, multiple recurrences, and they start coughing up blood or spitting up blood, what are you concerned they have? What's the disease entity that they may have? Have you heard of a sentinel bleed? Do you know what a sentinel bleed is? A sentinel bleed is someone that comes in with a head and neck cancer like this that's had multiple treatments, and they start coughing up blood. What you worry about is that one of the arteries has become ruptured, right? And so, in the US now, what we initially do now is to perform a CTA. Now, does anybody know what I'm seeing right here? What's that? It's actually not necessarily a pseudoaneurysm, but with a leap of faith, there's an artery here, and what's coming out of this artery? Contrast. This is acute extravasation of contrast on CTA. So if you see something like this, pick up the phone and call somebody. Pick up the phone and call your interventional neuroradiologist. Because I want everyone to be aware of what acute extravasation looks like on CTA. And this is acute extravasation. So you can see the contrast is out of the normal confines of the carotid artery. Now, the last thing that I'll talk about is the presence of effusions in the emergency room. So this is an example of a patient that comes in with a unilateral effusion involving what air cell are we looking at here? The mastoid air cell. So if you see a unilateral effusion of the mastoid air cell, where do you have to look at next? The nasopharynx, exactly right. And why? Why, Manal? Due to what? Due to what? Good. Why would a nasopharyngeal carcinoma result in obstruction? I'm going to keep asking you until. So you're exactly right. Realize that the back of the eustachian tube, the back of the pharynx is connected with the middle ear cavity through this eustachian tube. And if there's normal aeration of the eustachian tube, the mastoid air cell can be well aerated because of the air at the back of the pharynx goes into the middle ear cavity. But if there is an occlusion of the eustachian tube, now there's lack of aeration, and as a result, one of the complications is that you can have an effusion involving the mastoid air cell. So what we have to do is look for different disease etiologies that can somehow occlude the eustachian tube. And in adults, the most common thing is going to be a very, very subtle nasopharyngeal carcinoma that's located in this fossa. And what's the name of the fossa here? Starts with an R. Rosenmuller, exactly right. So the earliest locations of nasopharyngeal carcinoma to form are in the fossa of Rosenmuller. So once you have this tumor rising from the fossa of Rosenmuller, it's going to push this structure. What's the name of this structure here? It starts with a T. The torus tubarius. It's going to push the torus tubarius anteriorly. And if it pushes the torus tubarius anteriorly, what's it going to do to the eustachian tube? It's going to obstruct it and collapse it, okay? So one of the things to look for in the middle of the night, and even on all brain MRs, if you ever see unilateral effusion on a brain MR, you have to look at the eustachian tube, you have to look at the nasopharynx, as we said before. So this is a true effusion. This is an example of coalescent mastoiditis. So what is mastoiditis? First of all, sinusitis or mastoiditis It's a clinical diagnosis. It's not a radiological diagnosis. Okay, it's made by the referring physician in a patient that has some type of fever, and when they press over the temporal bone, it's tender. Now, what we see here is the correlation of imaging of coalescent mastoiditis. So not only is there a fusion, but can I convince you, if you compare, draw a line down the middle, and you compare this side to this side, can I convince you that all this labyrinthine bone right here, it's gone on this side? Everyone see that? So that tells me that there's been some erosion or some process that's resulting in erosion of the small bone involving the mastoid air cell. So in the right clinical situation, this is coalescent mastoiditis because there's absence of the bone. If this is untreated, this coalescent mastoiditis can go on and erode the inner cortex of the temporal bone, and it can result in thrombosis of the adjacent dural sinus. So this is clot all in the sinus. So you have this infection that's involving the mastoid air cell, and then it can extend posteriorly. If it extends laterally, this is what we refer to as a Bezold's abscess. So have you ever heard of Bezold's abscess? So what a Bezold's abscess is, and this is Frederick Bezold, right? Okay, you can go and read about him, right? So what Bezold's abscess is that you have an infectious process that's involving the temporal bone that initially was described extending inferiorly to result in an abscess of the sternocleidomastoid muscle. So Bezold described this years ago before CT and MR, and on the lower half here, that's the classic appearance to it. But now in 2019, in general, what we say is that we have some type of severe infection involving the mastoid air cell, and it extends laterally into the soft tissues, and here we have diffuse enhancement. This is all phlegmon. We now oftentimes refer to this as a Bezold's abscess. And that final stage is that if it extends in the brain, as is seen here, this is resulting in a frank intracranial abscess. So what's the normal progression of disease? Unilateral effusion, coalescent mastoiditis, Bezold's abscess, dural sinus thrombosis, intracranial abscess. That's the pattern of disease. That's a normal progression of disease. And we have to be aware we're in the middle of the emergency room in the middle of the night. We may run into any of those spectrum of diseases. So in summary, what we talked about was various infections involving the head and neck area. We talked a little bit about trauma, and why don't we stop there? So thank you very much for your attention. Oh, I don't have Joker in there. I have to add it.